Ladies and gentlemen, we move on to the next segment that's on pediatric cardiology, the challenges ahead. May I request the attention of Doctors Anita Khalil, Anjali Mathur, Poonam Malhotra, Sam Lingam, Archana Virmani, and R.S. Sambe. We'll have the first two lecture for 7 minutes, and the last lecture would be for 11 minutes. You're welcome. So I'd like to first welcome Professor I.B. Vijayalakshmi, Professor of Pediatric Cardiology at Sri Jayadeva Institute of Cardiovascular Sciences and Research, to speak for 7 minutes, which will follow with one quick question from the chair.
Good afternoon, friends. At the onset, I think I must tell everybody and the organizers that I am very happy to be here, and that is all because of the perseverance of Dr. Chopra, who sort of made it possible for us to come. Now today we'll be talking on congenital heart disease, and the speaker is none other than Vijayalakshmi, whom I've known for the last decades. She is a veteran pediatric cardiologist as well as an author par excellence. Now, congenital heart disease is such a topic, and when to intervene is very, very important. So we must know, at least to convey the message, that at what age a transposition of great arteries has to be tackled, probably surgically, so that the child may live. But a disease like atrial septal defect, which you can keep monitoring and wait till even in adulthood, the patient can be either surgically or the disease may be closed. So here is Dr. Vijayalakshmi. Please go ahead.
Thank you. Good afternoon, everybody. Respected chairperson, thank you very much for your kind words. 7 minutes is too short a period. In 1925, William Osler used to do inspection, palpation, auscultation, and then contemplation, because there was no intervention at that time. So what is intervention? That is, now we have ECG, X-ray, echo, and angiogram, and we take the benefit of all that, and to intervene is to come between the disease and the death. So literally, the congenital heart disease, when you want to prevent the death and give a whole life to the children, that's what you intervene. The first intervention was by Frostman, and at that time in the Nobel Prize lecture, Cournard said that this is the key, and true to his words, they have become prophetic, and today we have the key, and literally you name the congenital heart disease, we can cure them literally with the devices, balloons, and everything. So pulmonary stenosis, aortic stenosis, coarctation of aorta, AST, VST, PDA, AP window, rupture of sinus of Valsalva, and many congenital heart disease which are extremely rare. All of them can be treated without a scar on the chest with the device or with the balloon or with the stents. So the very first intervention was done by Rashkin and Miller, and when this was presented in a tricuspid atresia, people were horrified. Some of them got admiration and they continued with this, and today that we have interventions for whole lot of the patients. So here is the this is the TGA patient where it is not fit for surgery. We do the balloon dilatation for the pulmonary stenosis as well as the PFO, and then make the person fit and send for the surgery. This is in contrast a newborn baby with the pinpoint pulmonary stenosis. You can see that literally nothing is going into the lung. So with the PTCA guide wire I have crossed, and with just 1.5 millimeter balloon, make a little place and then go with the bigger balloons successively and then open. Though this is risky, this is literally life-saving. So hydrops fetalis, you know that it is almost 100% mortality, and unless diagnosed and treated in time, you cannot save the child. So this was just a 14-hour baby, was on ventilator because it didn't cry, and the pressure was not coming up because there was a pinpoint aortic stenosis. I crossed it with the Shinobi guide wire and dilated with the 4 millimeter PTCA balloon, and literally you can see that a pinpoint stenosis was opened up, and then you could see that it is opened, and now today the child is 7 years old and doing very well, and the gradient came down and the LV function improved from 30% to 60%, and the child is doing so well that the mother can't run behind the child. So this is how you can see. So age is not a criteria, weight is not a criteria. This is a 1.8 kilo baby with a pinpoint pulmonary aortic stenosis. You can see that the Prussian helmet appearance is there, and again opened with the mini Ty-Shak balloon, so literally life-saving. So this is a non-compaction LV dysfunction, and then the patient has got a severe aortic stenosis in a 4-year-old child. The moment you open with the balloon, the child said, अब तो मैं बेहतर हूँ, अच्छा हो गया हूँ. So that is the remarkable recovery that the child makes. So this is one of the most critical aortic stenosis I have ever seen. The LV pressure was 300 and the gradient was 242. And you can imagine if the child is going to the school, it would have dropped dead. So this is a lady with the 178 gradient across the aortic stenosis, achondroplasia with the full-term pregnancy, and the anesthetists were not ready to give anesthesia, and obstetrician was hesitant to do the cesarean section. So in the morning I did the balloon dilatation, evening she developed the labor pains, and then she was shifted and cesarean section was done. She was very happy. She came and showed the baby. I was also very happy. For 1 year she never turned back, and she came back after 1 year only when she was pregnant again. So that is the level of ignorance our patients have. And this is a patient on the echo. There was a valvar gradient, and on the pullback tracing it appeared as if there is a LVOT gradient, and we opened up, and then the child is doing well. Whenever the child used to come with the distension of abdomen, we used to say it is an Indian childhood cirrhosis, but today it is not true. We can do the CT angio, we can do the angiogram. Literally you can see that there is a membrane in the IVS, and the IVC obstruction has caused the obstruction, and then we have punctured it, dilated with the balloon, and the distension disappears, and we can open even the hepatic veins. We can insert the filter. In the past, coarctation of aorta, they used to die of heart failure or bacterial endocarditis or rupture, and even the mortality after surgery used to be very high, but today no more. Believe me, our teachers used to teach us, put all your eggs in one basket, but here this patient came with atrial fibrillation, pulmonary edema, in failure, and they had missed the coarctation. The child was on penicillin prophylaxis. So I opened the coarctation and did the balloon dilatation simultaneously, so the my rheumatic disease and congenital can coexist. So this patient was playing tennis and fell unconscious, and then he had a subarachnoid hemorrhage, and because they found the murmur and hypertension, the patient was sent and we did stenting. And here you can see that what looks like a dead end, almost like an interruption, even they can be crossed from the upper limb and the lower limb, and we can put the stent and get excellent results. So even in the newborn babies, this is a patient who was misdiagnosed as dilated cardiomyopathy and LV dysfunction, put on a inotropes, but the blood pressure was 220 by 120 in the upper limb in a 42-day baby. So you can literally see that it is like a dead end. Crossed it with the PTCA wire and dilated with the balloon, and the child is doing very well. So whether it's a AST, VST, PDA, AP window, coronary AV fistula, pulmonary AV fistula, all of them can be closed thanks to this great guy, that is Kurt Amplatz, who's the inventor of the Amplatz device. And wherever the AST is, especially the ostium secundum AST, and if the rims are adequate, we can close that with the device. And this is how the device is put, and whether we go from the LPV or RPV, within 3 months there is an endothelium grown on that, and the AST gets closed. The PDA is the one of the easiest. So in the past they used to have 4 inch to 6 inches thoracotomy wound for a small 4 millimeter PDA. Today we don't send any of the patients, including the patients with PDA with the PH. You can see that even in a newborn baby, 9-day-old baby with LV dysfunction, complete heart block, I have closed it transit from the aortic vein with the newer ADO2 and ADO2AS. These can go through the forefront and we can get an excellent results in the PDA. And AP window used to be like an open heart surgery in the past. You can see that even the AP window we can do the correct measurement and close it with the device with the excellent result. And the VST, whether it is the muscular, apical, multiple VSTs, all of them can be closed. Even with the dextrocardia, we can go through the jugular approach. Post-surgical residual VSTs and multiple VSTs, Swiss cheese VSTs, they all can be closed with the newer ADO2 and the devices. So whenever the muscle bundles are there and the device cannot go, what we can do is the smaller children, we can do the hybrid surgery. Surgeon opens makes the thoracotomy, makes a small nick on the RV and a spur string, and I go through that spur string and put the device and get an excellent result like this. And even in a small baby who has got a PDA as well as the mid-muscular VST, we can close all of them. This is the dextrocardia, where the dextrocardia in the past, the surgeon used to find difficulty. Now within 6 minutes, we can put a device through the aortic end and get an excellent result. Garbude shunts, the shunt is from the LV to the RA, and these patients used to go for surgery or they used to get complications, but today no more. For the first time in the world, the 12 cases of Garbude closed with the ADO2 we have presented. In the past, the Garbudes, because they are small, they used to be left, just show the device. Show the thing. This is how they used to have the vegetation and die, and then I realized that this is not the way that the children should die. So we started closing all of them. And okay, I'll just go to the last. Just skip, go to the last slide, last but one or three. Okay, pulmonary AV fistulas, coronary AV fistulas, and this is the presentation which topped the list of the top 20 publications. You can see that the coronary AV fistula closed with the ADO2, and here in the same patient we have closed the VST as well as the PDA. And this is the aortoventricular tunnel. The tunnels also can be closed with the device. So we can't say that there is a light at the end of the tunnel. We can say that there is a device at the end of the tunnel. So in a congenital heart disease, we don't have to blame each other. We can learn and then do the device closure, which is so precise and perfect that like this bird, we can just go deep inside and close through the small hole that is just 1 or 2 millimeter over the femoral artery and the femoral vein, without blood transfusion, without any scar on the chest, and we get an excellent result. So these device closures have come as a very attractive alternative, so attractive that everybody tends to do it, but then one has to be very careful because you can have problems if you get attracted without having a proper resting. So in the past, the difficult cases used to go to the surgeons, but today not only we treat all the congenital heart disease with intervention, in fact what the surgeons cannot do there also we can tread. Thank you very much for your kind and the patient hearing. Thank you.
Thank you, Dr. Vijayalakshmi. Can you tell us, in cases of VSDs, especially when there are multiple VSDs, and in a child, when the child is just about a year old, what would you suggest?
Ma'am is asking whether it's a fenestrated VST
Yes,
or like
yes.
a Swiss cheese VST. If there's a aneurysm of the perimembranous VST with the fenestration, I close it with the device because the whole device sits in the aneurysm. And if it is the non-compaction with the Swiss cheese.
Does the age matter? Because the heart is going to grow. Will the device stay?
Yeah, no madam, age is not a criteria, but of course the VST closures are done above the 5 kilos, but PDA can be closed even in 1.8, but VST is at least have to be more than 5 kilos. So there we can put the ADO2, which are very soft and very easy. The multiple VSTs can be closed with the ADO2.
Thank you very much, Professor Vijay.